treatment failure and resistance. The objectives, hopefully, that we'll meet after the end of this discussion will be as follows. We'll be able to define the treatment or virologic failure and drug resistance, illustrate the risk factors associated with failure and drug resistance, and describe the approach to treatment or trying to find solutions to drug resistance. I hope to achieve these following objectives by going through just a brief background and really going through clinical case scenarios of my patients over time so that we can learn from these patients and maybe talk about how to approach these patients from a clinical standpoint, thinking about your own patients, when we go through my patients. And then I'll leave you with some summary of key points, and then we'll open the floor to questions. So as you may know, or may not know, the ramp up of antiretroviral therapy has really been unprecedented. So there's really no disease where there's a lot of use of medication, with the exception of HIV. So with HIV, there has been an upscaling of use of ART in the last decade or so, with more than 27.5 million people around the world now receiving ART globally. And that's very, very good, because we really want to knock out or eliminate HIV if we can. However, as efforts to scale up ART and even pre-exposure prophylaxis goes on, and more individuals receive antiretroviral drugs, there might be a further increase in HIV drug resistance. And the reason for that is the more we use a drug in general, the more potential there is for drug resistance, because we might use it improperly or inadequately. And we'll talk about that some more as we go through this discussion. So remember that the goal of ART is as follows. So we really want to suppress the plasma HIV RNA or the HIV viral load below the limit of detection, because when we suppress the viral load, good things happen. Number one, we prevent the emergence of drug resistance. Number two, we prevent disease progression in our patients. So their HIV is not cured, but it is slowed down in such a way that they can live normal lives. And number three, it also prevents transmission. As if you still remember, a few years ago, the motto or the slogan for HIV World AIDS Day was U equals U, which is undetectable is untransmissible. So that's what we want to happen. So that's the main goal of ART, is to prevent progression of HIV disease and prevent transmission. So now let's go to the clinical cases, and hopefully we'll learn about drug resistance and treatment failure through these cases. So we'll start with hopefully the simplest case first, and as we go along, we'll make it a little bit more difficult. So this is my patient. He's a 33-year-old male with HIV. He's been on ART for the last 6 years, and he's on everybody's favorite regimen before the upcoming or the initiation of dolutegravir. So almost everybody, right, is on LTE, which is tenofovir, lamivudine, and efavirenz. Now he returns to the clinic very worried because of his recent labs. So this is his labs in the past 2 years, which we plotted over time. And he's very OC. And so he likes to look at his CD4 cells and his viral load copies. And as you can see here, his CD4 really ranges from 200 plus to 400 plus. And on the last check, it was 389. And his viral load was mostly undetectable, but he has two numbers above the limit of detection, which is 40 for this particular lab. So he has a 48 here in red and a 57. And so he's very worried about these numbers, which are above the limit of detection. But he denies missed doses. So he says, I really take my meds religiously every day, and he takes his meds on time. So this does not seem to be a problem with adherence or compliance. So given these numbers, is this already a treatment or virologic failure with those two slightly elevated viral loads, no? And so the answer is, we have to go back and figure out what is the definition first of treatment or virologic failure. So typically, the virologic failure is the inability to achieve and maintain virologic suppression below 200. So if you remember in our patient, his viral load numbers are just 49 and 57 or something like that, no? There's no numbers yet above 200 copies. So is this treatment or virologic failure? This is not yet virologic failure. This is what you call a viral blip. Parang blip, ganun lang siya. There's just a little bit of elevation. And so intermittent blips of low-level viremia, meaning it's above the limit of detection, which is 40, but it's not above 200, are not considered virologic failure and not associated with subsequent failure. So what do we do with this particular patient? So the best or the solution for this particular patient is that you just have to counsel and reassure him. You ask specific details about how he takes his meds, what time, when does he fall asleep, maybe he should change the time, things like that. So just reassure him that this is the nature of the test, that sometimes it can capture blips like this because it is very sensitive. So you will not switch regimens yet, and you will not scare the patient, or should not scare the patient. Earlier on, I was listening to your first lecture, and remember she was saying that we should not play the blame game. We don't blame our patients. We don't scare them. We don't judge them. So it's same thing here. No? This is actually not the patient's fault. This is just the nature of the test itself, because it's very sensitive. Sometimes it can pick up some things that it shouldn't pick up, and so there's a viral blip. And however, you will have to keep an eye on the viral load and just maybe repeat it in 2 to 3 months, no? Or if the budget is an issue, maybe in 6 months. But really just reassure the patient that he's doing very well and that he's not failing his current regimen and he can continue on his LTE. Okay, so pretty simple case, hopefully. Now let's go to another case. So this other case is a 31-year-old male, again on heart for the last year, again on LTE, no complaints of adverse effects or AEs, and has tolerated pretty well. However, in the last couple of weeks, he's been dealing with a lot of emotional stress at home. He says his partner has been unfaithful, and at work, he has this evil boss. So he's not doing very well either at home or at work, and he's been very depressed and very anxious. And so he's been missing doses here and there. But when you prompt him and you ask him, when did you really last take your meds on a regular basis? He says he's really stopped it about 2 weeks ago now because he just couldn't take it, and he just wants to stay at home and not do anything and just, be in his room, really very depressed. So when we looked at his labs and we reviewed his labs over time, and I know this is a little bit unusual because he can get viral loads every so often. And I know viral loads sometimes we only get once a year, but some patients like to get their viral loads because they have a budget for it, so they get it more often. So if you look at his numbers, prior to starting ARVs, his CD4 is very low, 24 with 6%. We did not do a pre-treatment viral load because we rarely do that here in the Philippine setting. We typically do it after starting regimen. So he started his regimen in February, and we were already able to check a viral load in May, which is 3 months after starting medications, and it's 1,000, a little bit above 1,000. But by September, it went up to 13,000, and by December, it was up to 42,000. And by January of this year, he consults. If you look at his CD4 is just kind of staying around the low range, but we should interpret this with caution because it's really very early to check a CD4. He just started a regimen, and we don't really expect it to increase by that much after a couple of months of ARVs. Okay. Now, is this now treatment failure then? Is this our definition of treatment failure? Does it meet our criteria? So let's review again. So the definition is really when an antiretroviral regimen is unable to control an HIV infection. It seems to be that way at this moment because his viral load is going up as opposed to it going down. No? So remember that factors that contribute to treatment failure include drug resistance, which we'll talk about, drug toxicity, which he's not complaining of any toxicity from the drug he's taking, or poor adherence, which he is doing because he stopped his medications because of psychosocial or emotional factors. No? Okay. So in more specific terms, when you say there is virologic suppression, it means your HIV copies are below 200, which we talked about earlier. And so the opposite is the definition of virologic failure. When you have copies above 200 and you're not able to achieve suppression, no, over time, which is what's happening to this particular patient. Now, there are also other definitions. So if you can also have incomplete virologic response, where you do not have virological suppression to below 200 after 24 weeks, or that's 6 months of antiretroviral therapy. And I'll show you later a graphical representation of our patient's number, so it's easier to visualize. And then you can also have virologic rebound, meaning you already have suppressed viral load at one point, but then there is rebound. So there is elevation of the RNA or the HIV number to above 200 on at least 2 occasions, no, after a period of suppression. And then we talked about viral blip earlier with our first case. Okay, so again, virological failure is the inability to suppress the virus with a viral load above 200 copies. And the factors that contribute to virologic failure is similar to those factors that contribute to treatment failure. So if you think about it, treatment failure is the overarching term, and under that there is virological failure, okay, so which is also occurs because of potential for drug resistance, drug toxicity, and poor adherence to ART. So the factors contributing to both treatment and virological failure are the same. And sometimes these are used synonymously. So sometimes they're used interchangeably, the treatment and virological failure. Now, this is a graphical representation of our patient CD4 and viral load over time. So this is pre-ART, so before he starts ARV. So we don't have a viral load. We didn't check anything. That's when he starts his, that's when he has his diagnosis rather. And then a month later, he's able to start ART, right? Again, no treatment viral, no pre-treatment or starting viral load here. We were able to check the viral load 3 months after therapy, and it's quite low after 3 months, but then after that, it starts to elevate instead of going down, flatlining, no? The CD4 count is still pretty flat because it's early after ART. Now, the 6 months after February should be around July. And so that's when we expect his viral load actually to be undetectable. And we did not meet that. And so this then fulfills the criteria for virological failure. Now, how do we approach this then? What do we do next? How do we treat this, so to speak? So we do have confirmation of virological failure. We have an HIV above 200 on 2 consecutive assays, right? We have more than 2 assays actually above 1,000 already. We want to assess the causes of virological failure for this particular patient. And roughly they're divided into 3. It's a patient-related factor, a viral-related factor, or a drug-related factor, right? So patient factors, the most common is, of course, poor adherence. Viral factor is, does the patient have transmitted or acquired resistance? And we'll talk about that in the next few slides. And drug factors, it's the factor of the regimen itself. Does the regimen have a poor genetic barrier? Is it easy to get mutations with the current regimen? And again, we'll talk about that when we talk about HIV genotyping. Okay. And then you can evaluate depending upon how long the patient has been off his regimen. So for this particular patient, we have been off for less than 4 weeks, which is to the right of your screens. So let's think about this particular patient and let's try to assess his causes for virological failure. So our patient, looking at his patient factors, he has admitted that he has been poorly adherent to this therapy because of emotional instability and psychiatric factors. We don't know yet if he has transmitted or acquired resistance because we did not have a baseline resistance test or a baseline viral load, no? So we'll talk about this, whether this is acquired resistance or transmitted resistance, but we are unable to know because we don't have a baseline virologic genotype. And then if you look at drug factors, his LTE actually has intrinsically a low genetic barrier to resistance, especially the efavirenz is known to have a low genetic barrier, meaning if you miss doses here and there, it's easy to get drug mutations against efavirenz. So now let's go to what else can we do to evaluate him further. Again, he has been off for about 2 weeks. So let's review. Does he have prior ARVs and a drug resistance history? So no, this is his first regimen. Does he have other medical conditions that we should be concerned about, that maybe is interacting with his medications, or maybe putting him at risk for poor adherence as well? So no, he has no other comorbidities. He did have a past episode of pneumocystis pneumonia, but he's no longer on medications for that. Does he have potential drug-drug interactions with non-ARV drugs? So no, he's not taking other meds. Actually, this is his only chronic comorbid condition, his HIV. Then we should consider and address factors that may impact adherence. So we should address, or try to address with him, his trouble with his loved one and his trouble at work. No, he has this evil boss. Maybe he can work from home, maybe, or change with someone else who has a different boss, or things like that. So we should listen to him and try to figure out solutions on how to achieve balance so that he can take his medications better. And so the next step after that, after trying to deal with his stressors, is then performing genotype testing. And usually you perform genotype testing when your virologic RNA is above, or your HIV viral load is above 500. No? In the Philippines, however, I think they want it above 1,000 for our genotypes that we send to the National Institute of Health. So what is an HIV genotype? So the HIV genotype is actually the resistance testing, which involves trying to sequence the virus or the viral genome, and it remains the preferred resistance testing method. And there are many available commercial assays which use a special type of sequencing. But in the Philippines, the one that is available to us is through the NIH. I don't know if other institutions already have the capacity to do genotype. I think it is just the National Institute of Health near UPPGH. And so they do the sequencing to try and detect changes or resistance mutations occurring in the viral population. So remember, the virus likes to mutate or likes to change and replicate 1 million times per day. And so there are mutations sometimes because of drug pressure as well. So this is what the assay tries to catch. Now I'll show you an example of what it looks like. So again, this is from the National Institute of Health. It has 3 columns over here. The first column shows you a list of drugs. So this is the list of HIV drugs that are available. The second column will tell you this list of drugs there. The second column will tell you the different mutations, as you can see here. So this particular patient has an M184I mutation. So if you still remember your basic biochemistry, those letters stand for changes in your amino acids. So this is kind of the building block. And so it shows you changes or mutations in these amino acids. And then the final column over to the right will show you an interpretation. Either it's still susceptible to that particular drug, or it's already resistant, as you can see here. So for this particular patient, for example, who has an M184I for lamivudine and abacavir, this has conferred a high-level resistance to lamivudine and a low-level resistance to abacavir. So it will show you all those information. Now, when should we order this drug resistance testing or this genotype? Now, so for this particular patient, our indication will be here in the middle: virological failure and HIV copies of above 200, right? But the other settings for ordering this type of testing is if you suspect acute HIV infection, so someone you catch early during HIV, someone who just entered into care regardless of the timing for starting ARV therapy, because this is the only way to catch transmissible drug resistance. And I'll talk to you about the definition of that in the next slide. But I know we don't do this in the Philippines because genotype testing is not available to everybody. And it is a little bit expensive, no? And our patients have to pay out of pocket for this particular test. The other reasons to order the drug resistance test or the genotype is for patients with suboptimal suppression, meaning the HIV RNA is above 200 already, maybe not yet 1,000, but getting there. And then pregnant patients actually will need drug resistance testing, ideally, no, if they have HIV. Now, drug resistance then is caused by one or more changes or mutations in the structure of the HIV that makes the drug inefficient or makes the combination of drugs ineffective, no? So it's unable to block or to do its job, and is unable to block the replication of HIV. Remember, that's the goal of ARV, is to do virological suppression. Now, all drugs, regardless of the class, are at risk of becoming either fully inactive or partly inactive because of the emergence of resistance. So there's no foolproof drug. Now, all drugs have the potential to become resistant because of inadequate intake or factors that lead to drug resistance. Now, there are two types of drug resistance that I was referring to earlier. One is acquired, and the other is transmitted drug resistance. So acquired drug resistance, meaning because of poor adherence, because we take our drugs inconsistently, the mutations emerge. So this is, we acquire it, no? We did not have it in the beginning, but because of poor adherence to medication, we acquire drug resistance, and mutations develop over time. The second type of drug resistance is transmitted HIV drug resistance. If you think about it, the only way someone will get HIV is through another person, right? And that other person may have been exposed to drugs already and may have drug resistance already. And so that drug resistance is transmitted to the person who just got HIV. So this is what transmitted HIV drug resistance means, okay? A subset of that is what you call pre-treatment HIV drug resistance, which means the drug-resistant virus is detected in patients who have not yet taken ARVs, who are just about to start ARVs, or individuals already who have taken ARVs in the past, but are reinitiating ARVs again. No? Basically, it just means that you got someone else's drug resistance even before you start therapy, because remember, you got your HIV from someone else. Okay. So just so we can imagine it better, or we can visualize it better. So before treatment, most of our virus that we get is what you call wild type, meaning it hasn't been exposed to any drugs yet. No, so that's pre-treatment virus, which is wild type, which is brown, and there's some hiding maybe resistant HIV strains, but majority is your wild type. And then when you start taking antiretroviral therapy, that wild type virus is very susceptible, meaning the drugs will work against it, so they will be gone, and the one that will be left behind really is your resistant HIV because it's resistant. Now, typically, you won't have emergence of drug resistance if you don't have adherence problems. But if you do have adherence problems, then you will start to get this multiplication of the drug-resistant virus in different colors, as you can see here. And then that's what you'll get eventually, a drug-resistant HIV. Now, in which case, your current regimen will no longer be effective. Okay, so our patient is fortunate enough and is able to have a genotype done. And his genotype looks like this. Now, a little bit different from the earlier genotype that I showed you from the NIH. No? He was actually part of a study. And so, as you can see, he has these different changes in his NRTI class and NRTI class. His PI class has no mutations because he has not been on a PI. And then if you look at the full roster, as you can see here in the first column, these are the drugs that we use against HIV, the different classes. And then these are the evidence of resistances. Okay, so he has many resistances for the NRTI class and some resistance to the NNRTI class and no resistance to the PI class. Okay, so how do we put that together and what do we do next? So recall that our patient was on LTE, right? Tenofovir, lamivudine, and efavirenz. He had no prior regimens and no prior genotypes. So what regimen should we give him? So this is his genotype over here, so you can kind of refer back to that. So this was his regimen that failed, his 2 NNRTI, which is his lami and tenofovir, plus his NNRTI, which is the efavirenz. No? So most likely his resistance will be to the NNRTI plus the lamivudine. And true enough, he's resistant to lamivudine, as you can see here, and he's resistant to efavirenz, which is here, right? And so what are his new regimen options over here? So his new regimen option is actually the dolutegravir, or an integrase inhibitor, which is the newer drug now that we're giving everybody who's starting ARVs are now being given LTD, right, as opposed to LTE. Bictegravir is also another integrase inhibitor, but it's not yet here in the Philippines. Or potentially we can give him a boosted PI, such as lopinavir, ritonavir, which is here in the Philippines, no? Which plus your 2 NRTIs, which is typically still tenofovir. And remember, he's still susceptible to tenofovir, so he still has at least one fully active NRTI. So potentially his new regimen will be dolutegravir, tenofovir plus lamivudine. Okay. Now, remember that before you switch him, you really have to go back to the causes of his virological failure, because even if we change his regimen, if he still does not adhere to his new regimen, then he will again be at risk for virological failure in the future. So you really have to go back and try to assess and talk to him about the importance of taking his medications on a daily basis in order to avoid virological failure. And in table format, this is what you want to go through with him. So you want to address patient or adherence-related factors. So for this particular patient, it really is adherence that's the problem because of his poor psychosocial support, his mental health disorders. No? So maybe you can ask him to seek behavioral therapy with a psychiatrist, or maybe you can do it yourself. Maybe he wants a low-dose antidepressant or things like that. No. Now, the other issue that also comes to play in the Philippines, which is very frustrating to us clinicians, is of course a system level factor where we come across supply issues, no? Where the drug is out of supply and your patients will tell you, we only have a month's supply. And so we have to go back every month because our supply of LTD or LTE is running out. And so this is something we have no control over, but it's very frustrating because it also leads to problems with virological failure, or even worse, that the supply is there, but it's already expired. And so many of our patients do not want to take near expiring or expiring drugs. And so it leads to a lot of stress and potential for virological failure in the future. Okay, so now let's go to our third case. Now, a little bit more difficult than the second case now, but I think you can do this. So this is an older male, 47-year-old. He's highly treatment experienced and was lost to follow-up for several years before returning to care in 2010. So this is one of my older patients. The CD4 count is very low. It's 37 and it's only just 4%. He's been off meds for a long time. And his genotype shows the following. And I think we have a poll question for this particular case. So this is his genotype. And as you can see, it's all green across the board. There's no evidence of resistance anywhere, which is a very good thing. But what does it really mean? And so this is my poll question for everybody. I hope everybody votes. There are more than 150 of you. And I hope you vote. These are the choices. Radnir, can they vote? But I won't be able to see it. So he has A, no drug resistance, as the genotype will show us. B, the genotype needs to be repeated. C, he has archived drug mutations. And D, the genotype is just wrong.
Ma'am, the poll has been launched. So
I see. Thank you. Yeah, I see everybody answering. Hopefully we can get at least 100. I was looking at the polls earlier, only about 78 people answered. So maybe if we can get 100. So we're almost half have answered. Couple more, hopefully. I'll give it until 1 minute and 30 seconds. So 15 more seconds for people to answer.
Yung mga naka-mobile po, I think you have to swipe your screen to the left to see the poll.
Okay, so it looks like out of about half who answered, the answers are kind of split, no? So about 48% think he has no drug resistance, as the genotype shows. About 28% think the genotype needs to be repeated, and about a quarter or 25% think he has archived drug mutations. And we'll talk about it. Thank you very much. Yeah, we reached 85. That's very good. For answering. And so the answer is actually, this is a little bit of a difficult question. No? It means that the patient has archived drug mutations. So the mutations are hiding because he has been off meds for a long, long time. No? So let's review. So this is what I mean. No? So if you remember this diagram earlier, before we start therapy, we have a lot of wild type virus, which is this in brown, meaning it hasn't been through drug pressure yet, and so the virus will not show any mutations. And then when you start antiretroviral therapy, there's an initial response. So a lot of that gets killed off because it's very susceptible, the wild type virus, and the one that's left behind is your resistant virus, as shown here in pink or maroon. And then when you have adherence problems, then you will build kind of resistance. So only the drug-resistant virus will start to grow, and it will grow a lot over time because you're not taking your meds correctly. And then you will then stop antiretroviral therapy, just like our patient. But when you're off antiretroviral therapy, remember that there's no more drug pressure. So these resistant HIV strains will hide. They will start to hide, and your wild type virus will start to come out again. So this is what happened to our patient because he's been off medications for a long, long time. The mutations that are hiding, or the drug-resistant type of HIV, are now hiding again. They're just in the background. And so what you will see is what you will catch is the wild type HIV virus, which has no resistance. So it's kind of tricky that way. So going back to the approach again for virological failure, now we're here to the left side because the patient has been off ART for more than 4 weeks. He's actually been off for many years. So earlier I showed you in the vignette that he has highly treatment experience. So we now have to review his prior ART and his drug resistance history. So let's review. And lo and behold, he has been on all these different medications from 1998 to 2010. And many of these drugs are no longer familiar to you guys because they're very, very old drugs. They're no longer in use because of the newer drugs that we have in the market now. So Combivir is actually AZT, or zidovudine and lamivudine. Nalfinavir is a very, very old protease inhibitor. DDI is didanosine, which is very, very old, NRTI. No? So he's been through these different regimens. His last 2 regimens are actually PI based. So this is tenofovir, this is tabudine, this is lopinavir ritonavir. And his last regimen before he finally quit taking his meds was Truvada, which is tenofovir and emtricitabine. So very similar to our tenofovir lamivudine, and Calitra is lopinavir ritonavir. So he's primarily been based on a PI-based regimen. So let's graph his numbers. So we were able to capture and go back to his viral loads and all his CD4s over time, dating back to 1998. No? And as you can see here, he does get virologically suppressed. So he'll suppress for a short time, then he'll come off meds again, then his viral load will go up. And then they actually were able to do 2 genotypes in the past before he became controlled for a short period of time here. But his genotypes, we were unable to recover his older genotypes anymore. So we don't know what mutations he had in 2004 and 2010. No? That was, this is now his most recent genotype, no, which we have, which is just wild type virus. Okay, so we were unable to capture the 2004 one. So what do we do now? So now we scratch our head and have a nosebleed because he's a very difficult patient and the genotype really was not very helpful. So after our nosebleed, we will go back to our next regimen. We'll try to figure out what's the next regimen for this guy who has been on primarily a PI regimen in the past. So he's likely failed the PI regimen. No, maybe we're not sure because our genotype is not helpful. So potentially you can actually restart the same regimen, or you can choose another type of PI, or you can choose now the dolutegravir or the integrase inhibitor regimen, which is what we have here in the Philippines now. So potentially, you could start him on tenofovir, lamivudine plus dolutegravir and just keep a very, very close eye on his viral load in the future. No? But again, you have to go back and try to figure out why is he not taking his meds. So you have to go back to the reasons for his non-adherence, no, that we went through earlier. Okay. So to summarize some key points, treatment failure is really defined as an unsuppressed viral load or persistent viremia above 200 copies. No, it can occur without drug resistance. So treatment failure is not the same as drug resistance. If you catch it early enough, and this is actually when you want to intervene before they develop drug resistance, you might be able to reverse the high viral load. Now, if you tell them you should just take your meds every day before you develop drug resistance, you might be able to reverse things. In contrast, drug resistance is the appearance of mutations in the virus that are very clinically relevant and lead your drug or your combination of drugs to be ineffective. And there are two types of drug resistance that we talked about. One is transmitted, meaning you got it from someone else, or it is acquired, meaning you did it yourself because of poor adherence to your regimen. Now, there's often negative consequences from drug resistance, which we didn't really go over, but I wanted to put here. The more regimens you take, the more there is potential for drug toxicity. And of course, when you're off your regimen or when there is an unsuppressed viral load, there is faster progression of HIV disease, and that's what we're trying to avoid. So these are the negative consequences of drug resistance. And of course, while it's not controlled, you are already at higher potential of getting sick again, of maybe of getting opportunistic infections, especially if your CD4 is still quite low. So remember the risk factors associated with drug resistance, and roughly you can divide them into three types, right? The patient factors, which is primarily adherence or maybe his chronic comorbidities, and things like that that are affecting his adherence to his medication. There are disease-related factors, meaning the HIV disease itself is making it difficult, no? And finally, drug-related risk factor, which is of course related to pill burden or maybe low barrier to resistance, which increases the risk for drug resistance down the line. But in general, really the most common cause of failure is poor adherence to the regimen. So this is where that lecture earlier really is very important, and we have to remember to try and convince our patients that they have to be adherent more than 90% of the time to their regimen. So that means taking the regimen 9 out of 10 times, no? And essentially, prevention of treatment failure and subsequently acquired drug resistance is very possible. Drug resistance and treatment failure is entirely avoidable and preventable if only if we are highly adherent to our regimens, no? And I think that is the last slide. Thank you very much for listening. I am happy to answer questions from the group.